ovarian cancer has the highest case fatality rate of all gynecologic cancers. So this is really a major health problem in this country. The way in which we approach this disease is really one size fits all. Patients come in, they undergo surgery, debulking, and then standard chemotherapy. This is where the exciting new developments are going to evolve over the next couple of years. We're no longer viewing these tumors as a homogeneous set of tumors. Some of them we can see differently under the microscope. Some look like clear cells, some look like mucinous tumors, some look like what we call serous tumors. But despite that, and despite the fact that the pathologists have always told us they look differently, we still treat them the same. We now know that those differences are important. So patients with one kind of tumor will get a slightly or potentially major different approach from a chemotherapy standpoint than other patients. The treatment will be tailored to the type of tumor the patient has. Best example of this would be the PARP story. So we know that there are subsets of ovarian cancer that have abnormalities in DNA repair. And those tumors are particularly common in patients who have BRCA1 mutations in their germline. Those patients can benefit from the treatment with PARP inhibitors. These are small molecule inhibitors that basically affect DNA repair, and the tumors are very sensitive to these. What's exciting is that there may be a whole other group of ovarian cancer patients who do not have germline mutations or are born with mutations in BRCA1 and 2, but are still sensitive to these agents. And so I think that what you'll see over the next year or two are attempts either through microarray gene expression patterns or mutation studies or other genomic approaches identifying other ovarian cancer patients who have what we would call a BRCA-like signature. And those patients will be triaged to receive, in addition to chemotherapy, PARP inhibitors. A final example of it would be clear cell tumors. Again, these look differently under the microscope, but still, patients come in, they get treated the same way. We now know through genomic studies that clear cell tumors have a very distinct set of gene expression patterns. At least two of those suggest that the tumors are very dependent upon blood vessels and what we would call a metabolic signature. Well, we now have agents coming through clinical trials which specifically targets the blood vessels of tumors and also targets the metabolic pathways. It's obvious that patients with clear cell tumors of the ovary should be treated with those agents. Clinical trials are ongoing right now to prove this approach. I think within a year or two, it'll become standard of care that patients with those kinds of tumors will see those agents. The one-size-fits-all will slowly reside into the dustbin of history in terms of the way we approach ovarian cancer.